Welcome to the second part of the series, Emerging Trends and Controversies in Reproductive Surgery. Today's webinar will focus on taking the business of ambulatory reproductive surgery and procedures. I am Sarah Ramaya, Curriculum Design Strategist and Webinar Coordinator at ASRM. Our moderator for today's session is Dr. Rebecca Flyckt. Dr. Flyckt is Associate Professor of Obstetrics and Gynecology at University Hospitals Cleveland Medical Center. She is the Division Director of REI and Medical Director of the University Hospitals Fertility Center. She is the Fellowship Site Director for the Society for Reproductive Surgery, Surgical Scholars Track. Before we begin, please note, this webinar was developed by the Society for Reproductive Surgeons and the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. Before we begin, again, please note, all attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks, so please watch your email for notification. I will now turn the presentation over to Dr. Flyckt.
Hello and good afternoon. I just wanted to thank Sarah and also Dr. Linnea Goodman for inviting me to host on this webinar. We all know that the REI landscape is changing amid incredible technical innovations, changing practice models, changing models of compensation. And so we must rise to this occasion. And I'm thrilled to be hosting these panelists, colleagues, and friends to talk about how to bring ideas for new technology to fruition, how to make this fit into your practice model, both logistically and financially, and also how to partner successfully with our advanced practice nurses in order to bring this increased productivity to the office. So I just wanted to introduce our first speaker. Coming up first, we have Dr. John Petrozza. Dr. Petrozza is a reproductive endocrinologist and reproductive surgeon. He serves as the chief of the Division of Reproductive Medicine and IVF, and he's director of the Mass General Fertility Center at Massachusetts General Hospital. He's also co-director of the MGH Integrated Fibroid Program, and I'm proud to say he's also the president of the SRS. And so John's going to talk with us about implementation of ideas into prototypes and then practice.
Thank you, Rebecca, for that wonderful introduction, and thank you for allowing me to speak on this topic of bringing new ideas into prototypes and in the practice. I have a feeling they're starting off with the oldest and going to the youngest in this webinar, and I very much appreciate that because I do think that over the last 20-25 years that I've been operating, I've had the opportunity to sort of have some touch points during my career that have really been involved with new innovative ideas and bringing technology to the workplace. So my disclosures, I am a consultant for Hologic and NESA, which are two surgical instrument companies. Now, as reproductive surgeons and even reproductive generalists as a whole, we are involved with procedures. It's what we do. Every day we're doing something, whether it's an egg retrieval or an embryo transfer, or whether we're in the operating room. We're working with instruments, we're working with patients. And it really brings a very unique perspective being in the reproductive world, because not only do we have access to this great technology, but when we introduce or think of new ideas and try to introduce this new technology, we have a very unique perspective. We're bringing it from an idea, we're bringing it to fruition, we're looking at the outcomes, but more importantly, we're looking at pregnancy outcomes, because for a lot of us, that is our primary goal. And so you'll see a lot of new technologies that are working their way through our professions and a lot of it has outcomes maybe on bleeding patterns or pain, but really there's a lot of data lacking on pregnancy outcomes. And I think as reproductive surgeons and reproductive professionals, that's where we have a unique perspective. So I'm going to talk a little bit about ideas and trying to get your ideas from your brain into a tangible thing that you can work with and hopefully introduce to people who also might share that same interest with you. If you're part of an academic world like I am, you have to develop a close relationship with your office for interaction with industry. You have to know the rules. You have to know the game plans. What things are you allowed to do? What things are you not allowed to do? And one of those things is always to have a non-disclosure agreement available. Whenever you start to interact with industry, whenever you have ideas and you start to have discussions, you want to protect those ideas. And a lot of times companies that you work with will have their own non-disclosure agreement, but I encourage you, and as I know your Office for Interaction with Industry will also encourage you, to have your own non-disclosure agreement. Protect your ideas, protect your interests. I can't encourage you enough to participate with industry. This is something that I've done since I started my career. It's a great way to meet people. It's a great way to get yourself known in the surgical industry. But more importantly, if you get a chance to work with certain companies, it's nice to meet the sales folks. That's going to be your frontline interaction. But really try to meet the engineers. Try to sort of understand what they're working on, what ideas they might have. Bring concerns you might have about their instruments to them so that you can interface and interact with them. Now, I have the luxury of working in Boston, so there's lots of surgical companies in my area. So I do have a little bit of an opportunity to meet with these companies and go to actually where these engineers work. But if you don't, I would encourage you to try to at least meet with them through Zoom or through phone calls if you can. And oftentimes your salespeople can start that introduction process. Reach out to local colleges for opportunities. Right across the Charles River here in Boston is MIT. And I have a really unique opportunity of working with some of the biomedical engineers that are there and with some of the mechanical engineers who often will incorporate into their classrooms opportunities for people like me, physicians, to come up to them and say, these are ideas I'm thinking about. Can we think of ways to make this particular instrument better? Can I work with you to try to come up with a new concept that I'm thinking about? And it doesn't have to be an MIT. It can be a local college in your area that might have a mechanical engineering program. I'm sure they're looking for brand new ideas to work with the students. Search out companies that work in product development. And I can't stress this enough. There are lots of companies out there whose primary goal is to get your idea, to develop it, and to get it ready to sell to a bigger company. And I can tell you with full confidence that the big companies like the Hologics and the Cooper Surgicals and the Medtronics love nothing more to have a product that is ready to sort of bring out to the market. They're not interested in trying to develop this. They want these smaller companies to try to develop it and bring it to the table where they can purchase it and then start to refine it a little bit more and get it out to the surgeons to use. Talk with colleagues who've gone through the process, and that's part of what I'm doing today, is trying to give you some insight on how to do this. But I can assure you that there's probably lots of colleagues who have come up with ideas, who have thought of new product designs, and have gone through some of this process. Bounce ideas off them, tell them what worked and what didn't work, and how to start this process for yourself. And participate in product research. This is how you get your foot into the door with these companies. Get to know the players, get your name out there. So problems are nothing but wake-up calls for creativity. And let me show you one of my first examples. So around 2003, 2004, I was asked to go give some comments on a new instrument that was being introduced, the hysteroscopic morcellator. And sort of one town from where I live is the company that was developing the hysteroscopic morcellator. It wasn't their idea. They purchased this idea from a European surgeon, but the European surgeon, the gynecologist who had designed this, actually stole this idea from the company that he went to. This design concept for the hysteroscopic morcellator was taken from what knee surgeons were doing. They were using technology where they were using a very sharp blade to fix meniscus tears. And this guy said, wow, why don't I use this for fibroids or intrauterine pathology? So he sold this to this company. They got FDA approval. They did the preliminary studies, but they didn't know what to do with it at that point. And so they invited surgeons like myself to come and give them some guidance. And one of the first things I said is, wow, this is great technology. Hopefully it'll work well with fibroids, but wouldn't it work well with soft tissue pathologies? I can envision this being used for polyps. I can envision this being used for retained products of conception. And at that time, the device was 9 millimeters diameter as far as the outer sheath. And I said, wouldn't it be great if we could do this in the office with the paracervical block? And they said, well, what diameter do we need to get this to? I said, no larger than 6 millimeters. Well, the company was interested, but didn't really have the bandwidth to really develop this product much further. So what happened is some of the engineers left and formed their own company called Tremont Medical. And Tremont Medical started to develop this product, hired me to be a consultant along with 2 other surgeons, and we provided the ideas and the advice to develop this product. And so they got this product down to a device that could be used in the office, a hysteroscopic morcellator that could be used in the office. The problem is that it was only going to deal with fibroids that were type 0 and type 1, FIGO classification. So it had a very limited appeal. Once again, I was making a pitch. It'd be great for polyps. It'd be great for soft tissue pathology. And so they started to work with this. And my involvement was working on product design, working on blade sharpness, working on what we needed to remove from the uterus. And the engineers did a lot of the other work. We did some initial pilot studies. We did some more studies in Mexico. And then we brought this to the FDA to get it approved for this particular device, and we got FDA approval. And luckily, we were able to sell it to a bigger company. We went from Tremont Medical to Interlace Medical, and Interlace Medical was the company that we had worked with to sell it to the bigger company. So here's an idea that started off just with a basic discussion in a group with engineers from a different company who saw that it needed more development, more refinement, and I was able to get involved from the get-go with this brand new startup that developed this even further. Work with people who are smarter than you, and don't be afraid to work with them as partners. And this is where I think if you have the opportunity to work with college students, biomedical engineers, mechanical engineers, you can really start to develop some really cool ideas. So I had a problem. I was doing a lot. I still do a lot of laparoscopic myomectomies. Most of my port sizes are 5 millimeters, except for my extraction point, which is usually a little bit larger. But most of my primary surgery and my ports are 5 millimeters. The problem is every time I tried to retract on these large fibroids, either my myoma screw was breaking or my single tooth tenaculum was ripping through the tissue. So I needed a device that could grab onto the tissue a little bit better and not rip. And so I went to the mechanical engineering group at MIT and I said, listen, this is my idea. They loved the idea. They decided to work on it, and this is the concept they came up with. Initially, they wanted to call this the Talon Grasper. I think the Talon Grasper was already out there and being used, so they're trying to come up with a different name for this. But you can see it's a beautifully designed instrument. It does look like the talons of a bird of prey. And so when they started working on this, they would send me questions, and they would say, Dr. Petrozza, how much force do I need, or can I put on this device? How dense is the tissue that you're using? I brought them to the operating room. I had them watch me operate. We pulled out fibroids. I had them play with the fibroids so they could get a sense of what I needed in order to make this instrument work. And they would send me these equations. And I'm like, guys, I have no idea what you're showing me here. They're like, this is proof of concept, Dr. Petrozza. You can see the force and the efficiencies of this instrument. What do you think? They're a lot smarter than me, and they clearly know what they're doing. And so the next step is to get this now into a provisional patent, which they've done, and to then start to look at markets, which at MIT, once a product gets through a certain design phase, it now goes to the business and marketing phase of MIT, where they can start to look at the need and do cost evaluations and market analysis to see what the need for this instrument would be. So this is a great story. It's great working with these young people who are really, really smart, and it helps me get new ideas out there to the market. So this is a device. We're testing it on on a small little olive here, sort of testing the strength of it. But it gives you a sense of the size of the device. About 9 years ago, to this same group, I proposed a problem I was having. I was doing a lot more robotic surgery at the time, and still doing a fair number of straight stick laparoscopic myomectomies. And the problem was that in order to manipulate the uterus, I either had to reach over and get myself out of position when I'm doing a straight stick laparoscopy, or I had to have a third year or fourth year resident there who was helping me during the procedure, or sometimes even a medical student. And sometimes I didn't have that third person to help me. Or if I'm doing a robotic case, I'm at the console and I'm relying on my assistant to manipulate the uterus for me. I said, wouldn't it be great if I could manipulate the uterus either from the robotic console or not have to reach over the legs to do this? And so I posed this to my smart students, and they started to work on it, and they love this idea. So you can see here, they're looking at the range of motion and the articulation. This is a handheld device. By rotating and squeezing the handle, I could basically maneuver this uterus into any position that I needed. And so this was fabulous. They asked me what size of uterus would I be working on. I gave them different sizes. They came and saw me operate multiple times to see what I needed. And you can see here, they're doing a proof of concept trial here, looking at this ex vivo. And you can see it's a really unique device. And it really was doing what I needed it to do. So we got this device and we said, listen, why don't we pitch this to a company? Well, the first thing I had to do, because I worked for Mass General Hospital, and because we were now at a point where we had gone through a provisional patent and we needed to get this into a more formal patent. Provisional patents typically cost about $5,000, but a full patent is going to cost at least $20,000, if not more. So this is a big step. So we decided we were going to either reach out to MIT or reach out to Mass General Hospital to sort of sell this idea. And Mass General Hospital was not interested in pursuing this patent. So I either had to put the money up myself, or I had to sort of sell this to a company. So we reached out to several companies who were well known in the surgical field, and they had an interest, but they looked at it from a financial standpoint and didn't feel like it would really take off. But I can tell you this was a great idea, and to this day I probably get at least 1 or 2 emails a month from people who see this on the YouTube and say, listen, is this product out? Because we really would like to purchase this. So if at first the idea is not absurd, then there's really no hope for it. And let me show you really an absurd idea that we had. And this is taking us from the surgical world now to the world of infertility a little bit more. And so probably about 7 or 8 years ago, a gentleman came knocking on my office door and said, listen, I'm an engineer. I work at MIT, but I also work across town at a different institution. And I pitched to this institution a cell phone that can do a semen analysis. And they weren't interested. Are you interested? I said, yeah, this sounds like a phenomenal idea. There had been some trials out there with some rudimentary devices trying to do this. I said, what do you have? He says, we can use the optics within the phone to create an attachment that can do a semen analysis. I said, what can it read? He says it can do a full count and it could do motility. It can capture these images, it can capture videos. I said, let's look at it. So we looked at it. We said, this is great, but we really need morphology. And what else can we do? So now with artificial intelligence, we've been able to get reliable morphology counts, and we can actually do hyaluronic binding assay scores with this same apparatus. And this apparatus with 3D printing costs us $5 to make. It's very simple to do. So now this technology, my embryology lab is run with this and is doing a lot more artificial intelligence work with this. We have at least a sperm analysis device out to some venture capitalists, to these middle companies who are trying to develop this even more. But this was a phenomenal idea that basically fell into our laps, and we were able to refine it and actually start to work on this a little bit more. So in conclusion, getting this idea to a product takes a little bit of work and a little bit of interest on your standpoint to sort of get this out there. Figure out what your institution controls. If your institution decides they have an interest and gets involved in getting patents, they're going to have some control of this product, versus if they're not interested, then this product is yours. And as long as you're doing this not during the regular hours, you should have some reasonable control of the product. To protect your idea, you want to make sure you find an attorney who specializes in contract laws, especially if you're in private practice, to protect your intellectual property. You want to determine the value of your idea, and these middle stage companies are very good at doing that. They can help you determine how much this idea might be worth. If you don't have a middle company to work with you, there are some appraisers who do this for a living, who can look at your idea, do some homework, and decide what the value of this idea or product might be. You want to start to think, if it's a great idea, start to think about how you want to option this. Do you want to have cash when you sell your idea? Do you want to have stock options? Once again, if you work with a middle stage company, they will do all this work for you. And then know your objectives. Do you want to just sell this idea to a company, especially these middle stage companies, or do you want to sell your idea and stay on as a consultant, or do you want to move on to something else that you're working on and stay on as a consultant only for these companies? And then start to identify potential companies who might have an interest in this particular instrument that you have developed. So thank you.
Thank you so much, Dr. Petrozza. That was a fascinating talk, and it's just such an interesting and unique way that you spend your time. I think it really speaks to the spirit of innovation that you've brought to your leadership at the SRS and just our field as a whole. And I just think it's amazing that you can go from an egg retrieval one day to a makerspace at MIT another day. So anyhow, thank you so much. I wanted to introduce Dr. Mindy Christensen, a friend and SRS colleague. Dr. Christensen is the medical director as well as the director of fertility preservation at Johns Hopkins. She also holds the title of associate professor at Johns Hopkins University School of Medicine. She is co-director of Johns Hopkins Fertility Preservation Innovation Center. And Mindy and I were just texting. She is also 2 classes away from getting her MBA, which is of course why these topics I think are of such interest to her. So Dr. Christensen, if you want to take it away.
Great. Thank you so much, Dr. Flyckt, for the nice introduction. I am so excited to talk to you about this topic, which I'm really passionate about, which is how office surgery and procedures can fit into your practice financially, because it is really important if we're doing these procedures. Obviously, we care about providing excellent patient care. That's very important, but also being able to enhance your productivity for your organization and your practice. I have no disclosures. Okay, so before I start my presentation, I want to present 2 different patient scenarios. So these are 2 different patients, very similar to patients you may have taken care of in your own practice. Patient number A, patient A is a 37-year-old gravida 0, para 0, with a history of polycystic ovary syndrome, obstructive sleep apnea, obesity with a BMI 48. On fertility evaluation, she's noted to have an endometrial polyp on saline ultrasound that's about 1 centimeter in size. She requires a hysteroscopy, and that hysteroscopy is actually performed in the general operating room because she's not a candidate for a procedure in the ambulatory surgery center due to her medical conditions. So she has her procedure in the GOR, which requires you to actually drive down to the main hospital 10 miles, spending significant time waiting for her case to start. Patient number B, or patient B, is a 38-year-old gravida 0, para 0, with male factor infertility who has a planned IVF cycle. She is noted to have an endometrial polyp on saline ultrasound, very similar to our other patient. However, she's able to undergo an office hysteroscopy with polypectomy in the office. So diagnostically it's noted and then it's removed at the same time. This takes about 20 minutes. She's total time in the clinic around 45 minutes. So we have a couple of poll questions. So the first poll question is for the audience. Of the 2 cases that I just presented, which one for your practice do you think would generate the most relative value units, or RVUs? RVUs are one of the things used to measure productivity. So one is the hysteroscopy performed in the OR, The second option is hysteroscopy performed in the office. The third option is that the RVUs are nearly equivalent. And fourth, you do not know. Sounds like most people were correct and selected the hysteroscopy performed in the office. That is correct. It's a little counterintuitive if you're not familiar with that, but yes, office cases will produce the most RVUs. So the second question, very similar, but we're looking at revenue. So for the second question, which patient case generates the most revenue? The one performed in the OR, the one in the office, the revenue is equivalent, or don't know. And it looks like it was almost a tie, so 41% OR, 41% office, 12% equivalent, and 6% don't know. The correct answer is actually office by quite a bit. So an office hysteroscopy will actually also generate the most revenue, which I'll be able to show you during this presentation. So let's look at a timeline of office gynecologic procedures, really focusing on office hysteroscopy. So office hysteroscopy was initially introduced in the 1980s, and then between the 1990s to the early 2000s, a number of new devices were introduced to the market. These included hysteroscopic morcellators, as well as tubal occlusion devices and endometrial ablation devices. So with these new devices, there was slightly increased use in office hysteroscopy. It wasn't until 2017 when the Center for Medicare and Medicaid Services, the CMS, introduced a new fee schedule. And that fee schedule significantly increased the reimbursement for physician fees for office hysteroscopy. And due to that, the number of office procedures did increase significantly. So how large was the increase in reimbursement for office hysteroscopy in 2017? It was on average 237% for hysteroscopic procedures, so pretty significant. And the next slide shows the example. So if we look at your typical hysteroscopy with endometrial sampling, and this can be either just a sampling or a polypectomy, so CPT code 58558. In 2016, if someone were performing the procedure in the OR, the reimbursement would be $271, whereas the following year in 2017, that actually decreased to $241. For the same procedure performed in the office, there was a significant increase in reimbursement from $410 in 2016 to $1,382 the following year. So pretty remarkable. Despite that significant amount of revenue potential, hysteroscopy in the United States today is actually still underutilized in the office. Today, nearly 75% of hysteroscopy procedures are still performed in the OR. And why is that? Why isn't office hysteroscopy more widely used? There's a number of reasons, and you may have recognized some of these reasons in your own practice. Number one is lack of staff buy-in, where while there may be some staff members or physicians that are very enthusiastic about starting office hysteroscopy, there needs to be the majority of people on board, and not all staff members may buy into the idea or concept of office hysteroscopy. A second issue is inadequate resources. Perhaps you don't have enough staff, perhaps you don't have enough space in your clinic to have an office hysteroscopy practice. The third is something I'll also be addressing as a way that you can look at this, and that's cost-related factors. So perhaps there's concern about the capital investment of purchasing hysteroscopy equipment or the cost of extra supplies. The idea that this may be very expensive and you may not be able to recoup that revenue or that initial investment. Another reason is not having established protocols. This is something that would be new that you're introducing to your clinic. There's not protocols. And then finally, being uncertain regarding which patients are the best candidates, not really knowing where to start. Despite that, office hysteroscopy provides many benefits, both to you and to your patient. It's more convenient to the patient. It requires no to minimal anesthesia. It's a situation where you can diagnose and treat in the same visit. You can diagnose a patient with endometrial polyp and remove it at the same time. There are in general less scheduling delays. It's not as difficult in most places to schedule a hysteroscopy procedure in your clinic versus trying to post an OR case. And then finally, greater reimbursement than in the OR or an ambulatory surgery center. A little bit more about reimbursement before I continue my talk. Payments for physician services are established by the CPT codes according to a fee schedule. So when you perform the service or the procedure, you enter a CPT code. Under the Medicare physician fee schedule, which is typically introduced each year, CPT codes are assigned relative value units or RVUs. The RVUs represent the relative amount of physician work, resources, and expertise needed. Payment for a procedure that you provide or a service that you provide will differ depending on where the service is provided. And insurers usually will base their reimbursement on the fee schedule. So that's why you should care about the assigned RVUs and the physician fee schedule, because most of the time insurers are following suit. So let's look at this example. This is operating room versus office reimbursement, and this is for a simple diagnostic hysteroscopy. So just a diagnostic hysteroscopy or CPT code 58555. So we want to compare performing it in the facility, in other words, the OR versus non-facility or the office. So first, let's look at the fee schedule. The fee schedule for performing today, the case in the OR is approximately $160, whereas in the office, it's almost twice as much, $334. And then if you look at the associated RVUs, the associated RVUs is 4.4 for the OR case and 9.26 for the office case, so twice as much. So this is important in some cases. Many physicians or other providers are actually evaluated by the number of RVUs, and things such as bonuses or supplements are measured or calculated using the RVUs. Now this is more of an operative hysteroscopy, so hysteroscopy with endometrial sampling. And so this code, CPT code 58558, also includes a hysteroscopic polypectomy. So if you perform this procedure in the OR, the fee schedule would be $243, whereas in the office, it's about 3 or 4 times as much as $1,430, so significantly higher fee schedule. If you look at the RVUs in the operating room, the RVU assigned is 6.74, whereas in the office, it's a staggering 39.6, so significantly higher, just performing in the office. There's also other indirect savings for you performing office hysteroscopy. It's easier to schedule. You yourself as a clinician have more control over your schedule. You can actually see other patients in the clinic while the procedure patient is being prepped or recovered, so you're making better use of your time. And there's also time saved with no travel time or no waiting for surgical delays. So there's a couple different ways that you can introduce capital funding if you wanted to establish an office hysteroscopy program at your practice. So one is to develop a cash flow analysis to demonstrate the benefit of office hysteroscopy. So the first step would be to work with an administrator at your office or a finance person to identify the estimated revenue from each office hysteroscopy procedure. And so this is going to be individualized for your clinic based on the payer mix and the negotiated fees. But someone at your center, some finance person, should be able to help you calculate the estimated revenue per office procedure. The next step is to estimate the variable costs. Variable costs are those that increase with each procedure. So for instance, for each procedure you perform, there may be costs with the hysteroscopy tubing, the fluid, the dissension media, disposable equipment. So those are going to be the variable costs per procedure. And then there may be step costs involved. So for instance, if you start to do a significant number of office procedures, you may need to hire an additional medical assistant, so additional staffing needs. And so there may be step costs you also want to introduce, or estimate. Finally, what you will do is determine what's called the contribution margin. So the contribution margin is going to be the revenue you'll make from each hysteroscopic procedure in the office minus the variable and step costs, and that will give you the contribution margin per case. So then what you can do is you can multiply the projected number of cases by the contribution margin to give you the projected annual revenue per year from the number of hysteroscopy procedures. So for instance, as far as projecting the number of cases, you may look at the number of total hysteroscopic cases you did the previous year in the OR and maybe estimate that starting out 25 to 30% you would do in the office. Another way that you can justify the capital funding associated with office hysteroscopy is to perform a break-even analysis. The nice thing about a break-even analysis is that you don't need to calculate the number of cases that you are going to do. You just need to calculate the number of cases you would need to do. So with break-even, you're calculating the number of cases you would need to do to pay for your investment or pay for your investment with profit. So let's look at the example on the left-hand side of the screen. So just calculating the break-even. So let's say that you want to purchase a reusable hysteroscopic system for your office, and the total cost is going to be $20,000. So you have this $20,000 investment. Now, let's say that you talk to your finance people, and the revenue generated per hysteroscopic procedure is estimated to be $1,300 per procedure. The variable cost is around $200 per procedure, so your contribution margin is $1,100. So basically, for each hysteroscopic procedure you will perform, your individual revenue will be $1,100. In order to calculate the break-even for this $20,000 hysteroscopic system, you simply divide $20,000 by $1,100, and that will give you the break-even point, which is 18 cases. So in other words, in this scenario, you would need to perform 18 hysteroscopic procedures in order to pay for your investment. The other example that some people will also calculate is break-even plus profit. So what this does is it sets a certain return on investment. So in the example I'm providing on the right, the return on investment we're looking at is 200%. So if we have a $20,000 hysteroscopic system, to have a 200% return on investment, we would need to have $40,000 in profit from the hysteroscopic procedures. Using the same example as the other case, we're looking at a contribution margin per hysteroscopic procedure of $1,100. So that means our revenue per procedure is $1,100. In order to calculate the break-even plus profit, you simply add your investment of the hysteroscopic equipment of $20,000 plus your $40,000 profit, so that's $60,000 divided by $1,100, and that gives you 54 cases. So in other words, you would not only pay for your hysteroscopic equipment, plus make a 200% return on investment by performing 54 hysteroscopic procedures in the office. You know, which if you're doing just even 1 or 2 a year, you would be able to obtain within a year. Or 1 or 2 per week, you would be able to easily obtain in 1 year. Okay, a few more financial tips for getting started. You know, there's different systems that are used. A lot of times single-use hysteroscopic systems will have a decreased upfront capital investment. So it's a nice way to get started with the flow of office hysteroscopy in your clinic. But because there's a decreased capital investment, you're going to have a decreased revenue per procedure because you're going to have a higher equipment fee per case. But examples may include the Endosee Advance as well as the Operoscope. Many people choose to purchase reusable systems such as the Olympus. And there's also a combined reusable scope with disposable device such as the TrueClear or the MyoSure. So in conclusion, office hysteroscopy can deliver increased revenue to your practice in addition to enhancing patient satisfaction. It can also offer for you indirect savings and easier scheduling and less travel time to the operating room. What you should do is work with your finance department to estimate the revenue per case to calculate whether it would be beneficial for you. there's a couple of different ways you can help justify the capital investment. These include performing a cash flow analysis or break-even analysis. Thank you so much for your attention.
Dr. Christensen, Mindy, thank you so much. That was terrific. I know that as you and I discussed recently, as relatively new IVF medical directors, these are great opportunities to increase both RVUs and revenue, really showing the outstanding work that our divisions are doing. You know, it's interesting that as a field, we are really being asked not just to be medically excellent, but financially productive. And so I think this is a terrific opportunity. I know that at my institution, we've found a significant increase in our financial success when we do hysteroscopy versus saline ultrasound as part of our cavity eval prior to IVF. And of course, it's the see and treat option that you mentioned. So hopefully people will have some questions about how to implement this within their clinical practice when we get to the Q&A. So thank you. Speaking of the Q&A, I did want to just mention, for those of you that are new to the GoToWebinar format, there is a question box on the side. I see that we don't have any questions yet. If you have questions either for Dr. Petrozza or Dr. Christensen or for Ashley Brown, our nurse practitioner who's going to present, please do put them in the question box and we'll make sure to get to those at the end. Okay, I wanted to introduce Ashley Brown. Ashley Brown works in our division at University Hospital's Fertility Center. As a fun fact, I just want to share that Ashley actually started at the front desk years ago. Then she went to nursing school and became a nurse. Then she went to school for her nurse practitioner degree. And I guarantee you in 5 years, she's going to be my boss. So I'm very excited to introduce her. And she's going to be talking about how to partner effectively with your nurse practitioner colleagues to increase the success of your office and help to build additional revenue. So Ashley, go right ahead.
Thank you so much for having me today and for that huge introduction. I don't know if I'll be able to live up to that, but I appreciate it. Today I'm going to be talking about partnering with a nurse practitioner in the fertility center and the procedures that the nurse practitioner may be able to help perform to utilize staffing in a better way. I don't have any disclosures to review. First, before we start talking about the procedures, we have to start talking about what is the scope of a nurse practitioner and what can they do in an office setting. It's going to be different per the state that you live or practice in. Every state has specific laws for a scope. When you're looking in general, there are 3 categories that the states are kind of filed into. The first one would be a full practice authority. The second would be a reduced, and the third would be restricted. I currently practice in Ohio, which is considered a reduced state, which includes Ohio, New Jersey, New York, Pennsylvania, and several others. But it basically just means that you have to have a collaborative agreement with the physician. In states that have full practice authority, such as Alaska, Arizona, Colorado, and many others, that was passed several years ago in about 2013. You don't have to have that collaborative agreement, and it may actually come with a higher reimbursement from Medicare or Medicaid because there's full autonomy there. When you're looking at the standard care arrangement, it's signed by the nurse practitioner and the collaborating physician. That typically will include the procedures that the collaborating physician has authorized the nurse practitioner to perform. Usually it will require documentation that the nurse practitioner is proficient to perform those procedures independently, and usually will be discussed between the nurse practitioner and the collaborating physician with how many would need to be documented with supervision prior to performing independently. Nurse practitioners who work for a hospital system are also required to go through privileging through the hospital and get credentialed. If you're working for a private practice that doesn't have a hospital affiliate, you might not need to go through that step. Looking at a list of procedures that the nurse practitioner can perform in an REI setting, it's a pretty lengthy list, but when you go through saline ultrasounds, HSGs, the newer procedure to the fertility world of hycosi, where we actually perform the bubble test to look at the fallopian tubes, as well as looking at the uterine cavity. Endometrial biopsy is a huge one that actually nurse practitioners can help with all of our endometrial receptivity testing that we're doing in fertility practices nowadays. Intrauterine insemination can be performed by a nurse, a registered nurse, If you wanted to utilize a tenaculum or a dilator, that then would be an advanced practice skill. So an advanced practice registered nurse or a nurse practitioner would be able to perform that. Diagnostic hysteroscopies, not operative. Ultrasound, going in and reviewing results with patients, or even in some settings, performing the ultrasound themselves. When you're looking at management of a missed abortion, we're talking medical management. The nurse practitioner could potentially prescribe misoprostol or help the patient through the process of expected management and even counseling with products of conception testing. When it comes to a surgical management, the nurse practitioner can partner and collaborate with their physician to get the patient set up for the procedure, discuss the risks and benefits of doing an in-office procedure versus a procedure in the operating room, and make sure if the patient has a negative blood type, ordering and administering the ROGAM. Management of pregnancy of unknown location or ectopic, again, reviewing results with the patient, counseling the patient, performing the physical exam, ordering any necessary lab tests such as a complete blood count if you're worried about blood loss, or if you're getting the patient ready to move to an operating room setting, getting those pre-op laboratory testing done. And then, of course, post-op visits with drain removals or suture removals, pending what type of surgery was completed. Some of the procedures that a nurse practitioner should not be performing, that really should only be the physician in the office, would be your surgical procedures, your egg retrievals, your operative hysteroscopies, DNCs, or IPAS procedures that we perform in our office, or methotrexate injections. In some states, a nurse practitioner may be able to do a methotrexate injection. In the state of Ohio, Ohio law says that nurse practitioners are not permitted to terminate a pregnancy for any reason. So they would not be able to do the injection, but they could always counsel the patient, calculate the weight-based dose, and get everything set up for the physician to complete. There are a lot of benefits of utilizing a nurse practitioner when we're looking at in-office procedures, and we just had a huge discussion about cost, looking at the cost of a nurse practitioner versus another attending physician, increasing the volume of diagnostic procedures. In our office, we see a lot of pathology, so that in turn increases the surgical volume for the RAA attendings and kind of takes one more step away from what the attendings would have to do to get the patient to surgery. So we know the patient has fibroids. We do a saline ultrasound to see if there's any submucosal components or what the grades are, and then we get the patient all set up and ready to go for their pre-op appointment with the attending so that they can then consent and perform their surgical procedure. So again, just taking one more procedure and one more visit away from what the physician would be required to do. Using nurse practitioners in an office setting are very cost effective. On the next slide, there's some studies that I was able to find that talks about the cost savings overall in healthcare of using nurse practitioners. Originally, when nurse practitioners started being utilized in an outpatient setting, it was more of a primary care practice where they were using nurse practitioners as an alternate to a physician. But in more specialized practices, such as reproductive endocrinology, they're being used more in a complementary role, where you're complementing the physician, helping with the procedures and seeing patients for follow-ups versus replacing the physician in their role, which would be seen in a primary care practice where you're seeing the patient alone for, 6 visits and things of that nature. When you're looking at a model for success when utilizing nurse practitioners in a collaborative agreement, you always want to make sure that there's clear expectations in the workflow so that the patients have the best experience and the office has the greatest productivity. You really want to make sure that there's an established plan for how the results are reviewed. So when you're looking at a saline ultrasound or a diagnostic hysteroscopy or a hysterosalpingogram, it's really reviewing the images with the physician, making sure you both agree on the outcome or the results, and then how do you convey that to the patient? Is it the nurse practitioner that discusses it with the patient? Is it the physician that discusses the results? And how is it documented? You need clear documentation when the nurse practitioner reviews it with the physician, which physician it was reviewed with, and what that final result is being reported out as. Utilizing technology to its highest potential. In the state of Ohio, with the collaboration agreement, the physician is not required to be on site just available via phone or email. So for example, I perform a lot of procedures at our Westlake office, which is about 45 minutes from our main location in Beechwood, Ohio. I don't have to have a physician on site with me to perform those procedures. The doctor will usually read remote, which is looking at those cine clips on ultrasound, looking at still images, and they're a phone call away if I need anything at all, which is highly efficient for our practice to have a nurse practitioner covering a satellite location that isn't performing any of the egg retrievals or embryo transfers. When you're looking at certifications for a nurse practitioner, obviously all nurse practitioners are going to be licensed in the state that they're practicing. I'm a certified women's health nurse practitioner, which goes with my licensing for the state of Ohio, but you can, if you're working specifically in fertility, you can also get certified through AIUM if you're going to be performing or interpreting ultrasounds. It's especially important to get certified through AIUM if your practice is certified through AIUM, because you want all of your providers then certified for the accreditation portion of it. ASRM has a certificate for an REI nurse. It's not specific to a nurse practitioner, but if you're hiring on a nurse practitioner that does not have previous REI experience, it would be a good idea for them to take this course to get background information about REI and the practice as a whole. And then looking at the difference between academic practices and private practices, you're going to see a lot of similarities between the two. But one of the things that I was able to research and even notice from my own personal experience is that private practices may utilize nurse practitioners more for your surgical first assist, your in-office diagnostic hysteroscopies, or even your follicle ultrasounds, as private practices in some scenarios don't have as many certified ultrasonographers, as many residents available at the resource. They may not have a fellow program. So a lot of the things that you may have within an academic center, you definitely have an ultrasound program. You have a resident, usually have an OBGYN resident program where you have a resident cycling through with you. You usually have a fellowship program. You have more hands on deck to help with those things. With a private practice, you may utilize the nurse practitioner in those ways that you don't have all those extra hands. A great way for a nurse practitioner to start out is also learning the FDA third-party coordination side of it. There's a lot of rules and regulations when it comes to coordinating those cycles, which may be advanced skills for a registered nurse, but may be more qualified for an advanced practice registered nurse. And academic practices, when you're looking at them having the residency programs and the fellow programs, nurse practitioners are also great in helping train or teach the residents that are coming through just the basics of reproductive endocrinology and infertility, because they typically have that knowledge base. And there's my reference list. If anyone has any questions, I think we'll take it to the Q&A.
Great, thank you so much, Ashley. That was terrific. So I'm looking at the Q&A and maybe some questions will filter in. But while we're working on that, just to kind of, again, thank our terrific group of panelists. And I think we're maybe just waiting for Dr. Christensen. Oh, there she is. Okay, perfect. Maybe I'll throw a quick question just to each of you. So to start with Dr. Petrozza, you know, it seems like you've had an incredible process of idea generation, and I know that you wear many hats at MGH. How do you find the time to innovate? Is that part of the time that your institution carves out for you? Are these pet projects? Do you have agreements with your institution about, you know, when you make agreements with companies, what stake in it you have versus the institution? Help us understand sort of the process of how we become like you.
Yeah, you know, the idea generation and working with these groups is all on my free time. So it's either part of my academic time or working typically after hours. So the classes for the students, for example, are typically done after hours. So I'll meet with the students, I'll catch the shuttle or catch the subway to MIT, sit down with them, buy some pizza, and we'll sit down and we'll just work on ideas and see how they're doing. It's just amazing to sort of be sitting there and sort of being in an environment where there's just a lot of energy and a lot of thought processes going on. And you start to see your instruments in a whole different light, right? We're so used to just saying, hand me that instrument and you work with it. But when you get down to the nitty gritty, and you see the complexities of these devices, you get a better appreciation of how they work. My stake in the game depends on whether or not my institution wants to get involved, and MGH is pretty picky on what they want to get involved with. They want to make sure that there's some return in their investment. So for most of these ideas, they balk. They're hesitant a little bit more to sort of do this. So a lot of the push is either going to be coming from me or through the MITs or the colleges who might have more of an interest, either through generating a product that has their name on it, or whether it's doing things with their students. Most of what I do in pushing this forward, especially with the students, is to be the liaison with these companies that try to develop a product, as I alluded to. And these are companies that usually have a business leader, a marketing person, an FDA consultant, and a bunch of engineers. So they're designed to take this idea from, let's say, the students who are working on this Grasper device and say, okay, let's do a market analysis. Let's see if there's truly a need. Petrozza says he has a need, but does the Christiansons and do the Rebecca Flicks of the world really think this is a cool idea, and will it sell? And if they see there's a need, then they will start to buy into this. And they're in it to make money. They're in it to refine this instrument. So now you've leveraged your expertise, and now you've given it to this company who's now going to take it and run with it, and you're just going to hang on for the ride and sort of see your idea unfold and potentially even make some good money in the process.
That's great. Thank you. So for Dr. Christensen, one of the questions I had while you were speaking is, we focused sort of on the procedural side, the physician side. What do you recommend if you're bringing office hysteroscopy to your REI practice? What do you recommend in terms of anesthesia support on site? What's your typical flow, and how have you worked that in?
Well, I think it really depends on your comfort level, but if you're starting out, like when I first started out, I was using a lot more anesthesia than I think I needed. I was having patients take Valium and oxycodone and an NSAID. In the end, they didn't really need it. And so I think it can be very minimal. It's kind of a fine line. If you're needing to administer anesthesia, then the patient may be better off in an ambulatory surgery center. It really depends on your particular comfort level, but for the type of cases that I would be starting off with or introducing, it would be like minimal to no anesthesia, and that's what I would recommend.
Perfect. So just for the greater audience, it's not like you need an anesthesiologist. These are medications that you're giving orally or a paracervical block.
Correct.
Okay, perfect. And then for Ashley, I guess one of the questions that came up, because this is in all of our, Facebook groups, is how do you partner best with a nurse practitioner? What would be your ideal setup between a nurse practitioner and the managing physician in terms of good communication about roles and responsibilities? Any pearls of wisdom that you can share with us?
The biggest thing is just open communication, having a good way of communicating back and forth, especially with patient follow-up. I think having the nurse practitioner performing all of these diagnostic procedures in the office is a great way to start. But then there's so much more the nurse practitioner could do to help the physician, following up on new diagnoses for thyroid disease or lab results, or implementing oral medication starts with Clomid or Letrozole and managing those cycles until the patient needs to progress to something like IVF, and then they hand back over to the physician. I think diagnostic procedures are just kind of the cusp of how you start, and then it could be expanded so much more from there.
Yeah, and I agree. And I think one of the things we've talked about together, Ashley, is, once we have a good flow and we feel trust as far as how the procedure is being performed, how do we ensure good oversight so that over time we can feel really good about the level of quality in terms of the care being provided to our patients in this procedural volume?
And I think that brings up another really good point when you talk about legal considerations. Obviously, a physician is going to have so much more knowledge base and experience when actually reading and reporting out results for those procedures. So having really good communication and follow through between the nurse practitioner and the physician when you're actually reading the report of the semen or of the saline ultrasound. saying, okay, I read it, I think it looks like a submucosal fibroid, what do you think? And then having the physician give their input before reporting out the final results.
And I agree with you. And I think the only word of advice I would have is, we've partnered really well, I think, with you and one other nurse practitioner in our practice, is that it's not a one-time thing. We continue to evolve what we're doing together. We continue a process of oversight and credentialing to make sure that we are all practicing in lockstep with one another. Okay, I want to go to the questions in the chat. We have a couple. So we have a question. It says, great presentation, thank you all. I've been trying to introduce office hysteroscopy, but I've always been told that the revenue is less than the operating room, which is obviously not right. Thank you, Dr. Christensen. We are a private office that is affiliated with the university, and we have our own surgical room. Where do I start to get information about the revenue? Thanks again. I'll send that over to Dr. Christensen.
Yeah, I think it's really important to work with your finance department to find out about your practice's payer mix and your negotiated reimbursement. So that's what you would need to find out first. But I think that once you find out the revenue that you can make with an office procedure versus a surgical in the operating room procedure, you'll be very pleasantly surprised. And I think a lot of centers may not be aware of that. But you need to talk to your finance department because each center is going to be different regarding the negotiated reimbursement.
Yeah, absolutely. And again, this is something we've commiserated on, but I think, sometimes people see business plans and, fixed costs and variable costs, and they think that's not the purview of the REI physician, but these days it is. And I think that, people like Dr. Christensen are getting their MBAs for exactly that reason. We're just responsible for so much knowledge about the practice of medicine, as opposed to, again, being medically excellent. There is another question for Dr. Petrozza. It says, Dr. Petrozza, you briefly touched on the patent process for the new technology that you helped develop. What is your best recommendation for learning the ins and outs of this process? This is from Danielle Lukish. It says, I'm a medical student. Our curriculum is limited on the business of medicine. I think that's true for all of us. So Dr. Petrozza, did you want to answer that?
Yeah, that's a great question. I think the easiest way to deal with this is twofold. If you're in an academic center, this is a great opportunity to work either with your office for interaction with industry, because they will have typically some patent lawyers in their office, or to find yourself a patent lawyer and sit down with them and say, listen, I don't want to hire you to do a patent, but I want to learn about the process. And most patent lawyers, I've done this before, most patent lawyers will sit down and spend 30, 40 minutes with you and explain the intricacies and the costs that are involved with filing a patent. Great question.
Yeah, I think that's a great question. I mean, I have one follow-up, which is, I don't know if other individuals on this webinar have gotten these kinds of requests, but I get probably several times a week requests for consultations, whether it's about new medical devices, evolving technologies, someone who wants to pick your brain about the REI space. And, I haven't really engaged, but I mean, sometimes they'll pay you $500, $1,000 an hour just to kind of get an idea of what your thoughts are about something. Dr. Petrozza, how do you advise sort of the general REI or the trainee to navigate those kinds of requests for consultations? Because I used to just give them away for free.
Yeah, it's always better if you get paid for your knowledge and your advice, right? And also usually these are done sometime in the evening, so you have to have time. This is time that's going to pull you away from your family and from doing other things that you want to do. I would pick and choose what you have an interest in. Otherwise, you'll find yourself inundated with sort of trying to, hear talk about a device that you may not have any desire or will ever use. And also rely on sort of where you see the trend is, where you think things are going, what things might help your office. Is there a new device that maybe you can use in your office that makes sense? And make sure that it's going to be an opportunity, if you can, to have some interaction with people other than the sales force, right? Because oftentimes you're dealing with the sales force, and listen, they have to do their job. They're trying to get you there. Sometimes they're picking your brain, but also they pick your brain for 10 minutes, and then the next 40 minutes you get a nice dinner and they're trying to sell you the product. So really, you can pick and choose, and you can ask, what are we going to talk about? Are we going to really talk about this product? Will my suggestions be taken, and used in some way? Are there going to be engineers in the room? Because you don't want to talk to a salesperson who's going to tell you they're going to talk to the engineering folks. You really want to talk to the engineering folks.
Yeah, this is great. All right. Well, I'm going to have to wrap up because of time, but I'm sure we could talk about this all day. Thank you for each of you, Ashley Brown, Dr. Petrozza, Dr. Christensen. This was a fascinating conversation. I really enjoyed it.
Thank you to our panelists and Dr. Flyckt for moderating such an interesting and important business in this segment of the series. And to our attendees, thank you for joining us. You will receive a survey right after this session by email, and your feedback helps us give you the most relevant content, and your input is appreciated. This session was recorded and will be available on our website in the coming weeks. Please watch your email for notification about future webinars. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar. Thank you.